Hello, hello. Hello, hello. That's better.
Thanks for joining us. And I'm glad that Felix, I'm glad you got to join.
Yeah, yeah, just
Is it
got
is it 2 o'clock on Friday for
sure
you?
is 2 p.m. Yep.
2 p.m.
Yeah.
Friday.
Yeah, on Friday. That's right. Yeah. It's the weekend.
That's so wild. So
Yeah, it
wild.
is. We're in the future. What's
I
even crazy
know.
is flying back from New Zealand to the US, you land before you took off.
That is strange.
Yeah, yeah, yeah. So time travel.
Time travel. Hello, Victoria. Hey, Judy. I love your backdrop, Judy.
Oh, thank you. It's in Wales.
Oh, nice. Love it. Love it. Well, welcome. I mean, we had quite a few register for this, but it looks like it's just going to be a small group. This is the first one we've done in the evening. Um, and Felix was kind enough to request it because of the time change, time difference. So I think maybe we'll just alternate future times. Sometimes we'll do it in the evening, sometimes we'll do it in the day. But I'm your host, Bridget Wallace. I'm a physical therapist, owner of 360 Balance and Dizziness in Austin, Texas. And actually, Felix gave me the idea about tonight's topic to talk about different dizziness and how it's related to different causes. And so I'm going to get started because I put together slides. I can find a way to get these handouts. If you're interested in the handouts, make sure I get the handouts to you. I'll be letting people in. And remember, you have a chat option. So if you want to ask a question, you can type it in. We can, I'll open this up at the end for you to ask questions, share your story. Um, and then I may be asking some questions along the way. And if you want to put your answers in chat, because I can see your video, you can, sometimes I like to say, for an answer, say one or say two. And you can, if you don't want to type, you can just hold your finger up. But just a disclaimer, this is because I'm talking quite a bit about diagnoses, different diagnoses. This is for educational purposes only. It is certainly not to make a diagnosis, and so I just want to put that disclaimer out there. I had a few learning objectives. Is well, not objectives. There's not going to be a test or anything, but kind of an outline of where I want to go with this. And we're going to I'm going to describe some different types of dizziness. I'm going to go over some timing and triggers, single events versus episodes versus causes, and then we'll open up the floor to see if you have any questions. So describing your dizziness. This is the hard part, right? People say, "Tell me about your dizziness." I'm gonna wait a little bit while Debbie joins us. There is what I want, the take home message is what I would want everyone to hear is there is no right way to describe dizziness. And so sometimes if I ask, I can, people are frustrated. I don't, that's not the point. Like there is no right answer to your dizziness. It's your dizziness. And it's just finding the best words. And there are no best words. There are no right words. And so even if I try to categorize it tonight, you may feel like, well, that doesn't fit me. And it's just, I'm trying to simplify the conversation, but we know we can always go outside of this kind of formal, structured kind of conversation. Dizziness is vague. Um, it's an umbrella term. It's used interchangeably. It's different. It has lots of meanings, and it really is what does dizziness, what does it mean to you? And that, the one thing I'll just will say as a healthcare provider about this word dizziness is because we bill insurance, we have to attach a diagnosis code. And we're referred patients with a diagnosis of dizziness, which has a number attached to it and a description. And so if you get a bill or you read your note and you see this as a diagnosis, not only does it say dizziness, but it says dizziness and giddiness. And it has said that for I don't know how many years. I don't like to see it. It seems like it's just a kind of a poor diagnosis. It doesn't really tell us anything. It doesn't tell us about you, what's the cause. It's just something that we have to use to use in medicine. And Felix is saying he gets giddy with a margarita. So in this, I am going to categorize it. So meaning like when I think about categorize, if I'm listening, I'm trying to go, not if, hopefully when I'm listening, I am going through certain thought processes about what people say and trying to, where does that lead me to? So there's three kind of big categories of dizziness. So if we put dizziness at the top, one category or one type of that is vertigo. And vertigo is an illusionary movement. Maybe you see the room spinning or you feel it inside. But any of you that have seen a healthcare provider about dizziness, one of the first things out of their mouth is going to be, is the room spinning? And you're like, don't ask me that again. It's not spinning. Sometimes people just come in, the room's not spinning. But it is definitely a go-to question. Is the room spinning? Or it can be an internal, like I feel like I'm spinning. I don't see things moving around me. Another is the second is lightheaded. So vertigo's one, you can see the environment spinning around you, or you feel it inside your head. Number two is the general lightheadedness. I just feel lightheaded. And so when we think of that, is it like faint-like? And like you could almost like if you've been bending over working in the garden and you come back up and you're like, whoa, I feel really lightheaded. Is it more like that? Because that could, now I'm starting to think, is this just a general lightheadedness? Is it associated with blood pressure? Is it associated with an elevated heart rate? Is it associated with both? Sometimes our blood pressure goes down, our heart rate goes up, and that can cause a lightheadedness. The third category is drunk-like, meaning a feeling of unsteadiness. And so maybe people like, I don't feel anything in my head really. I feel really unsteady. And here's my first question. You can put a 1 if you only have one type of these, or you can put a 2 if you feel like you have more than one of these. So you can type in chat, do you only have one type of these? Or do you, and you don't have to answer, how many of you would feel like you have more than one type? Most people have more than one type of dizziness. Rarely do we see one type. I mean, it may be one type, like I'm dizzy all the time, 24/7, but usually something else goes along with it. I feel unsteady. Sometimes I feel lightheaded. I feel dizzy. Spinning inside and unsteady. So these oftentimes there's more than one. Yeah. Sometimes there's 3. Sometimes there's 4 or 5 kinds of dizziness, which is something I have on a slide actually later on. The subtypes of this are rocking and bobbing sensations. Like I feel like I'm on a boat or just bobbing, rocking. And the fourth is falling or being pushed down. And when I call these subtypes, subtypes do not make them less important or less intense or less severe. They're just often not considered a type of dizziness. And we don't I don't know what rocking is, but rocking sensations, bobbing sensations, falling, like I feel like I'm falling through the floor. I feel like I'm being pushed down. Those are common symptoms that we hear. Now, we can't just take a symptom and put a category on it. That's too limiting. But so typically when rocking and bobbing sensations, so people feel like they're on a boat. It's interesting because we have an internal rocking in our bodies. It's subtle, but we have internal rocking. But there's an area of our brain that we know very little about in humans that is supposed to suppress that and take it down. And so, an example is if you've ever been on a boat and your feet are telling your brain that, hey, I'm on a level surface, and your eyes look around and see an environment, but your ear could be picking up the waves. And that's a sensory conflict. So your brain begins to adjust how it uses information. Then you get back on land and you've got sea legs, and it's like, what? Because your brain has changed the way it uses that information, and you feel the rocking. And then your brain is supposed to make that go away. Sometimes in some conditions that rocking can stay. But it's basically our brain is turned up the volume, maybe because our nervous system is and it's just hot, and it's not able to kind of tone things down. So sounds, light, stimulation are overwhelming because that system isn't suppressing it. Falling, being kind of pushed down through the floor, that can happen with anxiety. I'm not saying anxiety is the only reason why. If someone says, I just feel like I'm kind of walking on clouds, I think, well, I wonder what their sensation is like, because peripheral neuropathy, where we lose sensation in our feet, can make the ground feel different. It's not what we think. It's not as firm as we think it's going to be. And so these are all, they're descriptors. Did you know, however, that even though I'm a creature of habit and I read the literature says now that we're not supposed to be concentrating on these symptoms. The literature says they don't hold a lot of value, but I promise you, the next patient I see, I'm going to ask them, do you have vertigo? Do you feel lightheaded? Are you unsteady? It does bring value to me. That research came from when they interviewed people about their dizziness in the morning and in the afternoon and evening, that they would get different answers. It wasn't reliable because it may change throughout the day. So it's not that it's not important, but it's just so variable that we can't just only depend on, well, do you have vertigo? Do you have lightheaded? Do you have unsteady? We've got to dig deeper into those types of dizziness. And what the literature showed are there two things that give us the most insight. And that is the timing of your symptoms, which I'm going to talk about, and the triggers. So on our website, 360balance.com, which I provide you at the end, we have a tab on there that says podcast. And I did a season 1 of podcast, and I'm going to do season 2 in 2025. But in episode 3, I talk about this. The podcast is about this, and they're usually about 15 minutes long. But I provide you handouts of a symptom log around, less about rate your symptoms, because people are like, oh my God, I don't know, it's a 7, it's a 3, sometimes it's a 5, it's a 2. And it's so hard to rate your symptoms because they vary. And then you're like, well, I don't know, what's a 5 mean? What if 10 is the worst? Am I a 7? I mean, I don't like to fill out things like that because I'm like, I don't know, is it a 2 or is it a 3? So rating our symptoms it can feel stressful, and it doesn't provide a lot of value. What brings the most value is the timing and triggers. So what I'm going to walk you through is the onset, the duration, the frequency, what makes it worse, what makes it better. And if you want an actual symptom log based on this that you would want to take to your provider, it has these check boxes that you can think about the timing. Is it seconds? Is it minutes? Is it hours? Is it days? Is it constant? Is it, and so it's, the symptom log is less about rating your symptoms and more about providing this information. Because providers in general don't understand dizziness. It's poorly misunderstood. And oftentimes it's like, we call it the diagnose and adios. Like, here's a medicine, but it requires a lot of questions to understand someone's dizziness. And then, like, yeah, the triggers, we're going to talk about what makes it worse, what makes it better. And it doesn't mean you have an answer to that. You may say it's constant. I don't know what makes it worse. I don't know what makes it better. So we're trying to identify some clues about that. So vertigo, I'm going to first talk about it as a single event, one event. one big event that you remember, the date it happened or the time period it happened. These types of single event of vertigo usually last minutes to hours and sometimes days. And so when we hear that, I mean, we want to know, how long did it last? When did it happen? How long did it last? And were there any triggers? So when we use the word spontaneous, that means to us that there's no known trigger. People are like, I don't know. I just had it. I woke up with vertigo. Maybe a trigger. Some people were like, it started after I hit my head. It started after a fall. It started after a whiplash injury. People have vertigo after blast injuries. Sometimes medications, pharmaceutical prescribed medications, illicit drug use. Sometimes there's a known event that caused this vertigo event. So those are the kind of questions that bring insight. So I'm just going to go over, I see someone has written something, so I'm going to move some windows here so I can see better. The chat. I believe did I see something in the chat? Oh, I'm just making things up now. What I'm going to go over here is some common things that we see. So spontaneous, remember, spontaneous means we can't identify a known trigger. So what we want to ask is what people may not realize. Was there a prior illness? Was there associated hearing loss? And a biggie is, was there stress? So when we're stressed, it can make us prone to have a vertigo attack. When there's no neurological signs, imaging is normal, our eye movement's normal, our coordination's normal, the most common cause of one event of vertigo lasting hours, usually hours to days, is an inner ear infection. It's the most common. And I have vestibular neuritis, which is a type of inner ear infection. It is the third most common thing we see in the clinic. I'll be talking about what number 1 and what number 2 is, but it is the most common. So it's the sudden onset of vertigo, usually with nausea and vomiting. There may or may not be hearing loss. And that bad event never happens again. Okay. And there's also something else, wouldn't expect you to remember this, called Ramsay-Hunt. That's another type of inner ear infection. So a vestibular neuritis is vertigo without hearing loss. A labyrinthitis is vertigo with hearing loss. And Ramsay-Hunt is an inner ear infection that is typically vertigo, hearing loss, and facial paralysis, all on the same side. These viruses are the same virus as a shingles virus. So shingles is a herpetic virus that goes and attacks a nerve. It can be your skin, it can be here, what we think more of shingles, but it can attack any nerve, your inner ear nerve, your facial nerve, your eye nerves. So it is a form of the herpetic virus form of shingles. And so with our immune system, we have that herpetic virus in our body. So when we're compromised, our immune system's compromised from stress, from other illnesses, we are at risk for our immune system not to keep that herpetic virus at bay, and it becomes more active and replicates and attacks nerves. So inner ear infections are common. They're 98% of the time they're viral. So there's no pain, there's no temperature, and unfortunately, there's no good test for it. If there's hearing loss, steroids are the best treatment in the early phases. But oftentimes, if there's no hearing loss, it's questionable what can be done from a medicine. It's usually medicines to help the dizziness and the nausea. If you or you know someone who has the sudden onset of vertigo, like I'm thinking of a patient I know quite well, and he was at a baseball game, sitting there with his buddies, and no known illness, and on the ground with vertigo with no warning. When I hear that, Or I was fine. I was walking across to get my second cup of coffee. Before I know it, I was on the floor with vertigo. No illness, no upper respiratory. Hadn't been feeling good, just like that. My concern is there has been a vascular event or an ischemic or where the blood flow is compromised because it happens so suddenly and without warning. In other words, inner ear infections and blood flow ischemic events can mimic each other. And unless a certain series of bedside tests, not imaging, are done in the emergency department, it goes missed, an unknown of what the cause is. Unfortunately, that test that brings the most value is done less than 10% of the time because we rely on imaging, and imaging is not sensitive to this type of dizziness in the first 48 hours. So even imaging can come back normal in the early phases. And so I do acknowledge that oftentimes we don't know in these single events what the underlying cause is. If there wasn't enough illness, if there wasn't, under stress, and it happened without warning. And you probably can't see, with how small it is on your screen, but we think we have this big blood supply back here coming, our spinal cord comes up and becomes one big artery, and then that just goes out throughout our brain. And the more it goes into the periphery, into other structures, the smaller those vessels get. And we just don't have imaging. We have an artery that gets so tiny that it just goes to the hearing center, and we don't have imaging to pick that up. So we have limitations. So if someone comes in and, I thought someone was diagnosed with ear crystals and sent to me, but when I saw them, I was like, I think this was ischemic. I think this was a blood flow event. It happened suddenly without warning. The vertigo was bad. There was nausea, vomiting. I saw some other neurological signs in eye movement. But then I started, how well are you sleeping? I don't sleep. Do you think you have sleep apnea? Oh, I have sleep apnea. Do you wear CPAP? Nope. What's your cholesterol? It's high. What, stress level high, cholesterol high, untreated sleep apnea. So there's those risk factors for that type of more serious event. So, digging into the history is important. All right. So single events is one kind of category. The other is vertigo that's episodic. So it comes in episodes. So we come back to those two words, timing and triggers. Timing and triggers. When did it happen? How long did it last? Seconds, hours, days. What are the triggers? Again, spontaneous means no specific known trigger. But I've had repeated spells of vertigo. I don't know why. They happen out of nowhere. I don't have a warning. Or is there a trigger? Is it position changes? Is it lifting, straining, coughing, sneezing? Is it loud sounds? So those are known triggers associated with inner ear disorders. So we're going to take a look at those. If it's seconds to minutes, if someone comes in, it's like, I don't know, it lasts seconds, maybe minutes. I don't think it really lasts hours. Okay, well, what makes it worse? Oh, when I change positions. Okay. The most common is if it happens when I lie down and roll over, or maybe bend over or look up, and it lasts for seconds. BPPV, or those dislodged ear crystals, is the most common cause of seconds to minutes from those position changes. What if you say no? It's position changes, yes, but it's when I stand up or I've been standing. I get dizzier the longer I'm standing. I'm not thinking BPPV. I'm thinking I need to check their blood pressure from sit or lying down to sit to stand. I need, what's their heart rate doing? So the blood pressure, if it's when you lie down, when you roll over, that's suggesting I need to test someone for the ear crystals. If it's no, when I stand up, I need to be testing someone's blood pressure in different positions and their heart rate in different positions. So we have these conditions, orthostatic hypotension, where there's too much of a drop from, when you stand, it actually drops too much. Or maybe when you've been standing for a few minutes, it drops too much. There's also what's called positional orthostatic tachycardia or syndrome, or POTS. And that's when your heart rate goes up too high when you're upright. And both of those can cause dizziness. So we have three on this screen alone, three types of dizziness that can recur, common episodes that have known position triggers. So what we have to do is that gives us a targeted exam of what do I do? If it's when I lie down, when I roll over, I'm going to be looking for air crystals. And in the podcast, I think it's episode 5, I do a talk on BPPV. I think it's called Crystal Clear, Let's Talk BPPV. And I provide you a handout. When I was trained, actually with Dr. Epley about BPPV, we thought it was in 3 places. And I mean, 3 canals. And now it can be in 9 different places. So if you think about both ears, there's 18 possible places that ear crystals could be in the wrong place. So it does require someone who knows how to look at eye movements and determine where are those crystals so you get the right maneuver. So we've learned a lot about BPPV, and it's actually become a little bit more complicated than we realized. So we need to, these are very common. Again, BPPV is the most common condition that we see in the clinic. The inner ear infection of neuritis is the third, and I'm going to be telling you what our number one, BPPV is number 1. I'm going to be telling you what number 2 is. There's also this interesting episodic inner ear related type of dizziness. It can last seconds, it can last minutes to hours, and it's triggered by straining, lifting, coughing, sneezing, straining to go to the bathroom, time you increase pressure in your head, or loud sounds. So someone may say to me, oh, or checked it off on their paperwork, yes, loud sounds make me dizzy. Then my question is going to be, do loud sounds make you dizzy, or do they irritate you like nails on a chalkboard? So if it's like, oh, they're so irritating, that may be more related to our nervous system. When our autonomic nervous system is elevated, sounds can be sensitive, visual stimulation can be sensitive, any kind of sensory input can be a little overwhelming. But if it's like, oh, it makes me dizzy and feel unsteady, we've got to be thinking about a structural abnormality of the inner ear. It's called a third mobile window syndrome. And I'm not sure you can tell from the picture, but in this picture, this is called a dehiscence. So this is one of the semicircular canals of the inner ear, and there actually becomes a hole in it. That's what a dehiscence, or there's a thinning of it that may cause these kind of symptoms. And it's thought that this is often considered rare, and that's why a lot of people don't think about it. But a rare disease is when it occurs 2% or less. A dehiscence occurs in 20% of the population. It's just that we may not know it. We may have it without symptoms. Now, if people hit their head, they have a fall, they hit their head, or they have sleep apnea and they're snoring, that builds up pressure that there's a little protective layer of dural matter that keeps that from bumping against the skull, because this is embedded inside your skull, but that can get thinned out, and it starts with untreated sleep apnea. So untreated sleep apnea is considered a risk factor for a dehiscence. Superior canal dehiscence, that top one, is the most common. It's really one of the, rarely do you see the terminology third mobile window syndrome. You'll see superior canal dehiscence. But superior canal is just one canal. And now we know it can be, there's 15 sites for a dehiscence in the inner ear. And that's the one that can be seen on special imaging. There's more sites that cannot be detected on imaging. So this does require a neurologist. We can get an idea that someone has it based on their symptoms. So for instance, if someone comes in and says comes in episodes, it's seconds, minutes to hours, what makes it worse? Oh, if I blow my nose or cough or I hear loud sounds, I'm starting to think we need to do testing for this. So what's the next best test? To get a hearing test. And it has to be a comprehensive hearing test. It just can't be, do you need a hearing aid hearing test? It has to be comprehensive. And then that gives us clues. And then there's a diagnostic test that can be done. And then that recommends a special kind of imaging that's not commonly ordered. So this is another, some people don't think, why would I consider that a trigger? I mean, when we get people with dehiscence, they don't even want to tell us what their symptoms are because they don't believe that these are really their symptoms. Like a sound can make me dizzy, or if a dehiscence gets big enough, people will start to hear internal sounds like their eyes blink or their digestion. And so they don't think about talking to a provider about that. They don't think about mentioning, I hear my eyes blink. It's not the most common, but what we see is this is something that is often missed as a diagnosis. Okay, y'all doing okay? Do we got a 1 for okay and a 2 you're boring the you know what out of me? It's okay. I'll get a hint. This is really about you being able to ask questions. So give me a 2 if I'm boring you. Okay. I could talk about this stuff all the time. Okay. Another episodic. 5 minutes to 72 hours, no known triggers, it just occurs. Consider vestibular migraine. Most common is vestibular migraine. The most common thing we see in the clinic, BPPV. The second most common thing we see in the clinic, vestibular migraine. Number 3, inner ear infection. Those are more common than something we may hear like Meniere's disease. You usually have light and sound sensitivity. It may also include hearing changes during the event. Nausea, can be vomiting, can be visual auras, or headache. But when we hear the word migraine, we think there has to be a headache. Vestibular migraine does not have to have a headache. So there's thought that there's 2 things that cause migraines. It's inflammation of the trigeminal nerve, which feeds your face, your head, and it's an inflammation of the trigeminal nerve that causes pain, changes in sensation. The other type of migraine affects the vagus nerve. The vagus nerve is connected to everything in your body. That's why you can have every symptom associated with the vestibular migraine. It can be ringing, it can be nausea, it can be vomiting, it can be vertigo, it can be unsteadiness, it can be visual auras. If it's the vagus nerve and not the trigeminal, it may not cause a headache. So it does not require a headache. It is so common, and we have missed it for years. Before 2012, 14, when this became a recognized diagnosis. So really a very common thing that we see. Episodic, 20 minutes to 24 hours, no known trigger, occurs spontaneously. Meniere's disease. This is a fluid problem of the inner ear. It's accompanied with hearing loss. Yeah, I'll come back, Mary, and talk about, well, I'm going to make sure Mary understand your question. And then a hearing test is a must, because with Meniere's disease, it creates a progressive low frequency hearing loss. So Meniere's disease and vestibular migraine can mimic each other. They can sound the same, but the hearing test is the differential, because with migraines can cause hearing loss, but not the low frequency. They'll usually cause a high frequency. Meniere's disease causes a low frequency sensory neural hearing loss, which is a hearing loss from your inner ear. Mary, is there a treatment? I'm going to ask, is there a treatment we can talk about for vestibular migraine? If we go back to vestibular migraine, yes, it's a series of treatments. There's, it's a whole plan. There's some over-the-counter. I've been asked to do a talk just on vestibular migraine. And maybe I did a podcast on it. I think I did. I'm not sure. Vestibular migraine is over-the-counter for magnesium, riboflavin, which is a B vitamin, vitamin D, CoQ10. Those are common over-the-counter supplements. And then if the spells of vertigo and nausea are bad, then there may be a medication for that. There's some nerve stimulators you can use to try to stop a migraine. Management, wearing rose-colored glasses if you think you're going to have one. And there's this acronym called SEEDS, SEEDS, which I think we can apply to everything. The S is for sleep. How well do you sleep? What is your sleep habits? E is for exercise. What kind of exercise do you get? The other E is for eat. What's your diet like? And we can't just say a Mediterranean diet for all. We have to, really customize diets, even though Mediterranean diet is a big go-to for vestibular migraines. I did an interview with Dr. Bay, which is on our YouTube channel, because he wrote the book Victory Over Vestibular Migraines for patients. He's on his 3rd edition now, because he felt like healthcare providers weren't doing it. So he's like, I'm going to empower the patients. And here's the book. Here's what you do. And he and the Dizzy cook, Alicia Wolf, wrote a book called Managing Migraines, the Mediterranean Diet. So we have S for sleep, E for exercise, and it may not be that you have to go do 30 minutes. It might get starting with 2 minutes, 5 minutes, but getting up and moving. E, the other E is for diet, for eat, and then the D is for drink. What kind of fluids are you staying hydrated? And then the last S is for stress. What is your stress level and emotional well-being? And that's a whole big approach I think we could take with everything that we do. I don't think it has to just be vestibular migraines. Meniere's disease, how is that treated? It depends on what country you live in. In the states love diuretics, hydrochlorothiazide. They love to give diuretics for fluid problems. And that's to pull that excess fluid off the inner ear. So during a Meniere's attack, there's too much fluid. The sodium becomes higher than the potassium. The inner ear does not like high sodium. It likes potassium higher than sodium. That stabilizes the inner ear. If that gets out of balance, it can cause an attack. In other countries, it's something called CERC or beta histine. That's what's used in Mexico. That's what's used in Canada. That's what's used in Europe. It is a beta histine. It does not act like a diuretic. They're not sure how it works. They think it might increase blood flow to the inner ear, but really the States manages this through CERC or a beta histine is not FDA approved in the United States. And so people have to have it made. They can't have it. You can't have it made by a compound therapist, compound pharmacist, or you can order it from Mexico and Canada. So what a lot of people do here is they have it made, they try it out, see if it works, and then they know they can get it cheaper from Canada or Mexico and order it in bulk. So that's the big one for Meniere's disease, is really looking at how sodium and potassium, trying lifestyle first before more aggressive treatments. Okay, so what about, let's consider some others that are pretty darn common. We see pretty frequently in the clinic. The timing, it's constant. It's more constant. It may wax and wane, but it's pretty persistent. It's not a single event. It doesn't come in these clear episodes. It's kind of always there, but it waxes and wanes. It's been there for more than 3 months. What's the trigger? The initial trigger is it usually follows some type of an event, like an event of having a single event of vertigo. And instead of that just gradually getting better and going away, the dizziness stays persistent. It may be an emotional event. It may be a concussion, but it's usually another illness where something has happened and It doesn't have to be dizziness though. It can be just another event. And then it creates this chronic dizziness. Most people say it's there every day. It waxes and wanes. It's been there for more than 3 months. Usually movement makes it worse. And they're better with being still and lying down. And this is known as persistent postural perceived dizziness, or 3PD. This is super common. This is, still I'm going with our top three, but 3PD is very, very common. This used to be called chronic subjective dizziness, but now they have a recognized diagnosis for it and diagnostic criteria. So it's more than 3 months. It's pretty constant. It waxes and wanes. And the treatment, there's 3 things that have been recommended for treatment. It's all over the place on who does what first. There's a pharmaceutical, 3 things: pharmaceutical treatment, which is called the medicine SSRIs or SNRIs. So they have to do with serotonin levels. And then the second is what's called, it's cognitive behavioral therapy. Some people may go to counseling, some people may go, talk therapy, but cognitive behavioral therapy is a little bit of a different approach of how we retrain our brain to respond to different unknown triggers. There's also vestibular therapy has been recommended. So those are the top 3 recommendations for 3PD. What if someone says it's constant, it's been more than 2 weeks, I noticed it after I got off a boat? It can be, boat's the most common, like a cruise, particularly a prolonged boat ride. It can happen with the prolonged plane rides, prolonged train, or even car rides. Some people have reported this. It's resulting in rocking sensations that are worse when still and better moving. So there's no quiz, but I'm curious. If you looked at these 2 things that can both cause rocking sensations, can both cause dizziness, can both cause unsteadiness, are there anything besides the 3 months and the 2 weeks? Is there anything that stands out to you on these 2 descriptions that are different and be like, you don't have to take a guess at it, but I'm curious if y'all notice a key difference between 3PD and Maladie Department Syndrome, or MDDS. It's a clue. Anyone want to take a chance? You want me to go for it? Motion. Yes, Felix. So with 3PD, movement makes it worse. And with MDDS, movement makes it better. With MDDS, people don't like to be still. And it's not because they feel like they're going to pass out. It's not because they're getting lightheaded. It's they actually feel like, I cannot stop rocking. I am on the boat. What's interesting is this is for years, MDDS has been associated with after being on a boat. But now they've recognized a new type, and that's called MDDS-SO, which is spontaneous onset of MDDS, meaning people just get it. They don't have to be on a boat. We do see quite a bit of spontaneous onset MDDS. Now, it's usually after something. We've seen it. There is even a little bit. There's a suggestion that sometimes people have the onset of this after a dosage of steroids. Don't want to put that fear out there, but hormonal changes. Something that triggers, this is basically due to a sensory mismatch. Actually, both of these are. Our brain, if we get all this testing done, usually all the testing comes back normal. And people are really frustrated because all the testing comes back normal, the diagnostic testing. So it's kind of like the hardware works, but the way your brain puts all of it together is mismatched. It's like, it's not using your senses in the right way. It's typically over-reliance for 3PD and over-reliance on vision, and an under-reliance on our feet and our inner ear. With MDDS, it's not being able to tone things down, so that internal rocking just gets bigger and bigger. And so these are treatable. They're different. They're treatable in different ways because of the mechanism. So these are other types that we see in the clinic. So can you have more than one thing? Unfortunately, yes. Most people have more than one thing. And an example of that is it's not uncommon for someone to have vestibular migraines. And with vestibular migraines, you have a higher risk of getting BPPV and develop 3PD because of the chronicity, the symptoms become so chronic. It's not uncommon. Well, some people have Meniere's disease and vestibular migraines. Both of those increase the risk of BPPV, and because of like chronic symptoms, increase the risk for 3PD. So literally can have someone with vestibular migraines, Meniere's disease, BPPV, and 3PD. We can have someone with vestibular migraines, BPPV, and MDDS. And orthostatic hypotension or POTS can go with any of those. And think about all those different kinds of dizziness. Unfortunately, especially if you've been going from provider to provider, it's that there's more than one type. And that's why what you say, not what you say is right, but that we ask questions about timing and we ask questions about triggers, and we think, okay, there's different, and it's not going to happen in one visit. It's not going to happen in probably one visit. So it's like just keep trying to figure it out and find patterns. What kind of pattern can we find here? So yes, for sure, many people are dealing with more than one kind of dizziness. And I haven't, I'm not saying I've talked about all the types. So is there anything else? Yes, there's more inner ear diseases, conditions that I have not talked about. All right, there are more. There's a type of dizziness that's not common that causes vertigo, and it lasts a minute or less, and it can happen 30 times a day with no known trigger. And that's called vestibular paroxysmia. There's things that cause dizziness like tumors on the inner ear, where, people typically have the onset of hearing loss in one ear. They don't go see anyone about it until later down the road. They might develop dizziness, and then they go see someone, and then there's an MRI. And I feel like it should be a public, a public service announcement that anytime anyone has hearing loss in one ear, go get it tested. Because people say, well, I didn't get it tested because I listened to rock music when I was growing up. Well, rock music doesn't pick one ear. So anytime there's hearing loss in one ear, we want to know why. Okay. Dizziness is common with other neurological disorders. It's common with Parkinson's. It's common with multiple sclerosis. It's common with dementia. It's common with even just mild cognitive impairments. It's common with sleep disorders. So if someone says I'm dizzy when I get up in the morning, and I feel like there's this tight band around my head, it's like a vice grip, but as I get up and move around, I start to feel better. Then it's like, how well are you sleeping? Because that sounds like you might not be getting oxygen enough at night, which is important to know. There is an area of the brain. So when it comes to vision has been very associated with cognition. It is thought that 80 to 90% of what we perceive in the world through our eyes is going through some part of our brain cognitively. The inner ear has had little research in memory, but it is known that the inner ear is related to the hippocampus. And the hippocampus does spatial memory. Like, where am I in space? How can I navigate? How can I, do patterns? So decreased use of the inner ear can begin to impair spatial navigation and spatial navigation and memory. Your inner ear does not control your blood pressure, but the inner ear tells your autonomic nervous system where you are in space, so it helps determine how much blood flow is perfused, so blood flow perfusion. So if it's the inner ear is not giving adequate messages about where you are, especially against a gravity change, it could potentially affect the regulation of your blood pressure indirectly. We can have dizziness from visually induced dizziness, too much information coming in our periphery that overwhelms us. And it's just that our periphery is what tells us where we are in space. But when we feel dizzy, we just want to stare. Where are we going? We don't want to look, and we don't want any of that out there. But out there is what tells us where we are in space. So it's just all connected. Our neck can cause dizziness. When some people come in like, I think it's my neck. It could be. You know you better than anyone else. So we should look at the neck, because the inner ear and the eyes and the neck have intricate pathways that talk to each other. All three, something could be going on with all three. Like the inner ear helps with eye alignment. So do neck muscles. So we have to be looking at all of those. So this is just touching on a few parts of dizziness. So Felix makes a comment here. Laying down for too long gives a slight motion sensation. Cervicogenic. I don't know if it's cervicogenic. I'd have to look at the range of motion of your neck. What I hear when I see that is we've been lying down. We're not very we've taken a gravitational change. So the two things I would look at is now you suddenly come up against gravity. So there's the canals that we talk about that coordinate eye and head movement. The otoliths, which are the utricle and the saccule. The utricle is where the little ear crystals are. They do linear motion, like moving this way or moving up and down. The semicircular canals do head rotation. So the otoliths are gravity dependent. The semicircular canals are not. So the otoliths respond to tilt. They respond to lying down and coming up and changing positions against gravity. So that's what I would think from inner ear wise. Could the inner ear, you're in this phase and now you come up against gravity and the inner ear is not giving you enough information. The other thing I would look at is eye alignment in upright and lying down. Because sometimes there can be an eye misalignment in the vertical plane, like one is higher than the other. And if there's an inner ear component to that, when you lie down, it decreases it. If there's a ocular motor nerve causing it, when you lie down, it doesn't change anything. So I would want to look at both, do some inner ear testing, but also look at eye alignment. And certainly look at the neck. But I'm just, sometimes I think when people have been on their phones and their head's hanging, and their head's been in this forward head position, their eyes have been in this very close convergence, which we shouldn't be in for very long periods of time. We got to move our eyes. The 20-20-20 rule, every 20 minutes, you got to look 20 feet out and hold it for 20 seconds. Don't get stuck on here all the time. The eyes don't over converge here. Give your eyes a rest. Look up. Every 20 minutes, 20 feet for 20 seconds, look at something in the distance. Get your eyes out. So it could be, but it could also be inner ear, it could also be visual. Oh, yes, Judy. Osteoporosis in the neck, spondylosis can cause balance problems, 110%. They send signals about where we are in space, where our head is in space. If our heads, if our muscles are stabilize our neck, aren't equally activated and not doing their job, especially if our head's forward and our neck muscles are stretched out, they can't activate. So we got to really get up in this head position. Work on those muscles to stabilize the head because they could make us feel dizzy. It's called cervicogenic dizziness, or they're trying to get it, just the neck can cause dizziness, but absolutely can cause balance problems. So just working on those things, working on those things. All right. You've asked some great questions. Do you have any other questions for me? I feel like I monopolized your time. Do y'all have any questions? Something you want to share? Do you find the webinars helpful? Okay, excellent. So I got a recommendation for the next one. So these recordings, I've started a YouTube channel to be able to put these somewhere. So we'll just keep building it up. And I'll also be sending out, so you don't have to write this down. I'll be sending out a thank you and a link to those of you that registered. You can also email us info@360balance.com. On our website, we have the podcast show. We have what's called Blogtopia, where we put blogs on there for different subjects. But next month, a patient yesterday said, I have a topic I want you to talk about. I don't know how to talk to other people about my dizziness. I'm embarrassed. She said, like if I go to a restaurant and I'm sitting there and I'm facing the fan, that fan could make me have, as I turn my hand, I talk with my hands. That fan can make me have a migraine. And I feel embarrassed to ask to change positions. How do I talk to family members of like, I can't have that? And how do I talk to healthcare providers? I have if you've been on these before and you've heard me talk about Liz, we go a long ways back. And she feels like, when I have to have a medical procedure done, I'm trying to tell them like all these lights, if you have to have anesthesia and you get pumped with fluid, she has fluid problem of the inner ear. So those excess fluids you have to have with anesthesias can cause Meniere's attack. The lights can cause migraines. It's like just letting other providers, the impact of your dizziness. And I was like, that would be a great resource, like handout to give people. Like, if you want to go talk to a family member, if you're about to have a procedure, or going to the dentist, a patient was telling me, like, I went to the dentist to have my teeth cleaned, and I was like, oh, I really don't like to get back too far. And they're like, oh, I'll set you up whenever you're ready. She's like, no, I don't like to get back too far. I don't care that you can set me up. So I don't know. I think it might be an interesting topic. I'm not sure I'm the one to do. I was thinking I'm gonna think about it. I might get patients to talk about it. Patients. How do they talk to people, or maybe a coach? I'm gonna think about this one. Does this put a 1 in if you think you're interested in this topic, if it is of value. How to talk to other people about your symptoms. Is that helpful? Because if you've never had dizziness, you don't understand it. If someone says, oh, I've been dizzy once, or I've been dizzy before, they don't understand what you're going through, or they would never say that. The name of the podcast that I do is called I'm Just Dizzy. And it's not out of disrespect. It's how many times I hear I'm just dizzy. I even saw a doctor write that about a patient. I'm just dizzy. And I was like, oh, I've got to name the podcast Just Dizzy. Something about being just dizzy, because no one's just dizzy. If they're seeking care, it's affecting their life. I've got to see a question up here. How does one know if the Epley or barbecue roll is called? Excellent question. Okay, Felix, I've got a question for you. Do you know how to do the Dix Hall pike? Yes. Okay, so you can unmute yourself, Felix, or you can type it in. If I was thinking of my right ear, and I was gonna do a Dix Hall pike, what direction would my head be turned?
To the right.
To the right. And what
is the
would
Dix
be
Hall?
starting and sitting, right? Go ahead, Judy.
What is the Dix Hall
Oh,
pike?
okay. The Dix. Oh, I shouldn't have even said Dix Hall pike. That's why thank you, Judy. Most people don't know what the Dix-Hallpike is. That's the test that we do. Most people know what the Epley is. I should have clarified that.
I don't.
So an Epley is a maneuver for ear crystals. So a lot of people have had ear crystal problems, and they get the Epley maneuvers the most common because it affects the canal. It affects. That's where these ear crystals get in the wrong place. When you lie down, when you roll over, usually it's worse on one side. The room spins. You see the room spinning. It's usually less than 40 seconds.
Okay.
And that's when those ear crystals. So a lot of people do these self-treatments, an Epley maneuver. It's named after Dr. Epley. Is Felix, if you're doing it for the right ear and you think you're going to do a treatment, when you turn your head to the right and you lie down, that's the first step of the Epley, but that's actually the test that we do to determine. So if we take you back and you say, oh my gosh, there it is, and it's the right posterior canal for the Epley, your eyes are going to be going, the world's going to be going up and to your right. It's going to be going that way. And that's like, and then it slows down and you're like, oh, okay, I'll do the Epley for that side. And you're like, no, nothing happened. And you sit back up and you're like, ooh, feel a little dizzy. You turn your head to the left, you lie back. And if it's in the left posterior canal, which is the most common, it's going to be going up and towards the left. The world's going to be going counterclockwise. It's going to be going clockwise. So the first step is the Epley is actually the Dix-Hallpike test. And so if nothing happens in either of those positions, then you probably don't have BPPV in one of those canals. And then the roll maneuvers for the horizontal canal, and that's where you tuck your chin. You lie back, you tuck your chin, you roll over to your right, and it makes things go crazy side to side like that. And you're like, oh my God, and you wait and you roll over to the other side and it makes it go crazy again. That's hard to know which side it is because it happens on both sides. So that requires someone looking at your eyes, or if you're like, oh my God, it was so bad on my right during the roll test, then you do the roll maneuver. Does that answer your questions?
How about the Dix-Hallpike? What's that?
So the Dix-Hallpike that's the test for BPPV, for those ear crystals to be out of place. And that's like people sitting up in bed, they turn their head to the right. I mean, we do this in the clinic, and then we lie them down. We look in their eyes and see if they have vertigo. That's called Dix-Hallpike. It's named after the two physicians who came up with the test.
Okay.
That's a test for ear crystals. When you first started doing the Epley maneuver for this, you had to be trained by Dr. Epley or by video we had. And then the internet came out. Now everybody does their own self-treatments. It's all over the place. Do y'all have any other questions? So, and remember, I'm going to go back to think about Judy said. And this is interesting because it was really a conversation I had with one of the last patient I saw. Is I did find things, and she's like, "Oh my God, there's just one more thing I have," and I'm like, "I know, I'm sorry." However, it's something we can treat. Now, we may not be able to cure the spondylolisthesis or you're working on, weightlifting is one of the weight bearing activities, one of the best things for osteoporosis. So good exercise program.
Right.
Those are things that we can do things for. Even if we can't make something go away, there's a lot we can do. And the more we recognize all the different things, like not sleeping well and it affecting our dizziness, affecting our balance, affecting our memory, being under stress, affecting our dizziness, affecting our balance, affecting our memory, pain, causing dizziness, neck pain, causing dizziness, affecting our balance, affecting our cognition. So all of these things, we want to be doing the best to treat them all together.
That's very helpful knowing that that about stress and some of those things the neck pain.
Yeah. I mean, if we're in pain, if we're having dizziness, we're afraid of falling, we're in fight or flight or freeze.
Right. That's
We're
right.
in survival mode. We're in protective mode. And when we're there, we don't learn new things because
Mm.
we're in survival mode. We don't learn new things in those states. And so it's like, okay, well, I did this, but if I'm stressed and I'm in pain and I'm doing this, then it's almost as if it might feel like you didn't do it or you don't remember doing it, or I can't carry that over. I can't carry that over. We get the best carryover when we can minimize pain, get out of fight, flight, or freeze. That's when we have the capacity to learn.
Okay.
Okay. And you can't tell yourself not to be stressed. I mean, wouldn't that be great?
Yes.
If I, oh, don't worry about that. Okay. Thinking about it's going to make me worry about it. I know it doesn't work that easy. It's a process. It's a journey. Some days we're good at it. Some days we're awful at it. And just give ourselves some grace and, know there's lots of stuff to work on. So sometimes working on your neck could be the best thing if you're coming in dizzy and feeling foggy and like, okay, let's focus, let's work, let's do a little bit or finish with some soft tissue. Let's just get some of this out, okay?
Great.
All right. Thank you all so much. Y'all have a blessed Thanksgiving holiday.
Thank you.
And I'll be staying in touch.
Okay.
Thank you.
Thank you so much. Good night.
Thank you very much.